All right, we can get going. Welcome everybody. Our Zoom session for Module 15. Dr. Neil Soares will be leading the discussion this evening about emerging technologies. I really don't have any announcements other than we have tonight, and then our last Tuesday Zoom session will be in 2 weeks on April 5th for the final Module 16, and that'll be led by Dr. Turner. Anyone have any questions before we get going? All right. Okay, Neil, I will hand it over to you, and you can be off and running.
Great. Thank you so much, Mike. And thank you for joining me today. We're going to talk about emerging technologies, which is going to be broken up into two parts, really. This is a module that goes back prior to COVID, and it's just so fortuitous that the telehealth has become far more prominent. But when I started doing this, we did not have a pandemic, and so there are some things that have evolved. We're going to try and be equitable in the distribution of time for the two topics, because at any point in time, I've learned from past sessions, one topic gets everyone so energized that we end up doing a disservice to the other. So I'm going to keep a very close eye on the clock, and I'm going to ask Mike to help me, that we sort of split the difference between the two so that no one topic gets, the monopoly on today's discussion. So Mike, if you don't mind, if you can cut us off at 6:15 for the first half, and then we can parking lot anything else in case the second half is last. So we'll do that. First of all, I just want to remind you guys that part of this module sort of expectations were that, we looked at the assignment, we looked at the little video and the Camtasia file, and we're ready to answer the three questions today. Question one is really for the first part, which is how is technology a game changer for persons with disabilities? Question three is really for the second part, how can telehealth help? And then the second question can be equally divided. How can we be better advocates for technology access? And that could be straight up wearables or other technology or telehealth access. So that way of sort of say, question one is really for the first part, three is for the last, and the two we can sort of mix and match. So I have learned so much from the trainees every time I do this, that I really want this to be your forum. I want this to be you guys bringing your ideas, your comments, your thoughts, your criticisms, because this is not supposed to be a monologue. So I want you guys not to feel shy. Unmute yourself. If you want to raise your hand, that's fine. Of our usual Zoom etiquette, let somebody finish talking before the next person goes in. So if we remind, and thank you again, Mike, for posting that in the chat. So I'd like to hear in your practice, in your field, with your clients, what have you seen technology access be really improving their quality of life or their engagement with society or engagement with their providers or their clinicians? And then you can also talk about, and I'd like to hear, when you think it's been detrimental or when you think that it's not been all it's made out to be. So please speak up. We have time. We have this question. And Mike, I was thinking, so if we think about three questions to be answered, right? If we did 30 minutes each, so really what we'll do, even though we're stopping talking about emerging technologies at 6:15, maybe you cut us off at 6 for this question. So there'll be 15 minutes of question two, which then bleeds into 15 more minutes as we segue. Can you help with that?
Sure.
Okay, so please, the floor is yours, all the LEND trainees, the faculty, please. And, hopefully those who feel a little shy about talking, please put in the chat. Mike will be sure to capture that as well.
I can talk about in my role. So I am a social worker, but the work that I do primarily is quite different than most social work. It's not one-to-one engagement. It's community trainings, it's advocacy, it's that kind of work. And I've seen the use of assistive technology benefit a lot of advocates. During the pandemic, we had programs who got funding for iPads and hotspots and different things like that, so people can stay connected or be connected who otherwise were not engaged. So people are able to go to legislative advocacy days or that virtually, and they would have never been able to, whether it's because finances, lack of, transportation, whatever that meant, be able to do that. And the project that I work on, one of the projects that I work on, all of the trainings that we deliver are led by adults with intellectual and developmental disabilities, and they're all virtual. So we've been able to get people from different areas and they be able to do consistent work without needing to worry about how they're going to get there, mileage reimbursement, accessible transportation, because some people utilize wheelchairs. So that's how we've been able to use this virtual space and different devices to help people stay connected or get connected.
I thank you. That was an absolutely wonderful synopsis that really talks about the interconnectivity and how it is so important to understand what it does for people who have challenges with mobility or finance or, work-life balance, caring for their children. They can enhance their professional education, access content. So, Amelia, that was very well captured. I'd like to hear other examples. That is a fact, and I'm sure the example she gave applies to so many of us. But mix it up a bit. I think, what other things have you all seen? And I want you to broaden your minds about technology. Don't get hung up on traditional technology. Think about, when has somebody used technology in innovative ways? I think in last sessions, Mike has had, trainees last year and stuff bring up stuff I had never even heard about that was being used in the field. And we were sort of making furious notes and getting web links. So, talk about traditional technology, but also expand our minds with, non-traditional and emerging and cutting edge, and maybe somebody got a device that's barely on the market and is testing it out and stuff like that.
I can, I'm also a social worker, but I work with, I help people kind of live independently so they can stay out of group homes. Some of it, it's like Amelia was saying about the iPads, but they're kind of equipped with different apps, or a lot of, there's new, like those smart speakers, where they're actually attached to a screen so they can ask a question. I've also seen where if someone is maybe in a wheelchair and doesn't have too much range of motion, but they're still able to use their hands, they can control such thing as their lights, lock their doors. There's watches, smart watches where they can just press one button and they can make a phone call to their parent or their family members, or they can make one request to the smart speaker and bring up the person for a video chat to connect to either their friends, family, or staff. They can control anything from their heat, their lights, so anything from, and also if they need assistance, their caregivers or people that even aren't there can also have some control over it too if they need to. So it just really promotes a lot of independence.
Fantastic. Wonderful.
One just kind of isolated one that I saw in use as a medical student, and then I actually found out that a friend whose husband, who is colorblind, and it works for blind or just colorblind, is you just hold your phone up and it will tell you the colors, and then when you're doing your dressing, you make sure that you match that day. And she's like, I don't have to make sure his shoes and pants or something doesn't match. He does it all by himself now, once somebody told us about this app. And it's not like a super big thing, but it's that extra step of independence of not having to worry about either not matching or having clashing prints or something like that by yourself.
That's absolutely fantastic. There are lots of apps that can recognize a lot of things now. There are things where you can just take a picture of something and it'll tell you. People have been using that for plants and herbs. So, sometimes people aren't sure what it is, want to be sure it's safe. There are apps for that. But yes, I've heard about that one, Nicole. Thank you for bringing that up. There was also an interesting app that is able, and I forget whether, and if somebody is working with visually impaired people, please correct me, but I believe there was an app that is also able to tell people, obstacles that are coming up. So as they're learning to use their cane and other things, they can talk about distances from places. Other examples, please. These are fantastic. Keep going.
One of the things that I think about when I think about assistive technology is not just, our apps or our gadgets, but I think about those day-to-day sort of little widgets, like a lot of kitchen gadgets that we think of that are one-use items. Those are assistive technology, like electric can openers or like little pry bars to help open soda cans and things like that. And I know in today's society, we see those things and we think of like, well, that's stupid, that's useless. But, if we think it's useless, it's probably not for an able-bodied person. And I think that's a big problem is people see these little assistive gadgets and think that like, well, that's not an important thing when it is the difference between somebody's dependence and independence.
Amelia, that is absolutely spot on. One of the biggest problems with products today, and this was in the lecture and stuff, they have not been designed necessarily specifically engaging and incorporating the feedback of individuals with disabilities. They're created by tech geeks and people in marketing and people in business, and then they're put out there to get the maximum bandwidth. Who are the maximum number of people who will purchase the product or purchase the license or the subscription? And there's something to be said about user-centered design. There's something to be said about who is truly your customer and have you included the customer in feedback? Because if you haven't, right, then you're doomed to fail because you're excluding those people and they would benefit the most. Yes, profit is important. Don't get me wrong. I think it's important for companies to make a profit, but there's a balance in making a profit and also serving the needs of your constituents, right? So being equitable is what we're all about. And if we're only going to think about money and cut out the people who can't afford it or who have not been involved in the design. I love what in one of the videos, Haben Girma said, it is way cheaper and more efficient to build a skyscraper and design it with an elevator and accessible sort of pathways than to have to tear it down and repair it because you couldn't meet the needs of people, right? So at the end of the day, we have to think about disability as more broad-based than just ramps and touch screens and stuff. A lot of people, particularly with intellectual and socio-emotional disabilities, they really need to have things that are designed in a way that's beneficial. I mean, how often are things made which take somebody's sensory input into mind, right? I've known wonderful places where they will have, I believe there's one of my patients is asking me about a hairstylist for her child with autism. And there is this website and this app which lists the so-called, autism-friendly salons, and you can put in a zip code and you can find them. So that's another accessibility thing. You're coming up with information and people are trying to do stuff, even if it's not about, daily living skills or assistive technology type things. So there's a lot out there. Has anyone worked with, knows of, or has experience with the newer virtual reality, Oculus, Google Glass type of things? I'd love to hear about it. Angela? Yes.
Actually, we use those VR glasses. I have a son with autism, and his behavior analyst used them to put my son into scenarios where he had high anxiety, like the amusement park. We've never taken him to an amusement park, so they simulated the entire, walking into the park and so on, and it was very helpful. And I'm seeing an increased trend with these VR glasses, just to help relieve some of the anxiety some of these kids may have. I'm actually currently looking for one for an airport. So
kind of going up what you said for Angela, so not as high tech as the VR glasses, but I do know that there are videos out there to prepare kids, like when they're going to the airport for the first time or flying on a plane for the first time for kids with autism. I don't remember who does them, but they're just on YouTube. It's a free video. And I think there may be one for like a Disneyland type situation as well. But it's not like with VR, it's just a video on their screen, but kind of probably where that started.
And going off of that, I know that some people have used VR for dental visits too, because a lot of kids are nervous about going to the dentist, and that kind of helps introduce them to that setting instead of having to go to the office and do it in person.
What about other things like tactile technology? So that is even more cutting edge than the VR. They have developed haptic gloves now where you can put them on and you can do things. In fact, there's something where you can actually do sign language and it translates it from the glove into text for somebody who needs to sort of comprehend what is going on. There's a lot of good stuff out there. And I remember, Mike, the last time somebody had talked about something very cool happening in Lansing when they were talking about visually impaired people crossing the street, and there are certain things that can be done. So there's a lot out there. And part of the reason to have this discussion with you guys is you guys are in so many different roles and so many different disciplines. You guys have to be the advocates. You guys have to be the vetters. So, you want to be sure that these products are safe, and we don't know everything, but that doesn't mean we can't look it up. That doesn't mean we can't reach out to the person who developed it. That doesn't mean we can't say, hey, you know what? I've got clients who could be benefited from this, but I want you to explain it to me in layperson language, because if you can't explain it to me, then what chance you're going to explain it to other people? I'm interested and I'm engaged. And if you can't engage me, then how are you going to engage a skeptic? So and the other thing that's happening a little bit at a time is we're seeing a sea change in Silicon Valley and a lot of other places. Many of the companies are now really incorporating user-centered design. I'll give you a great example. For years, they used to just make products because they can make products and sell them. But now they're actually hiring engineers and software designers and others who have disabilities or who have family members with disabilities. And they want including them in the creative process right from the beginning, from conceptualization. Not, here we built a product, focus group, what do you think? No, tell us if this is of value. Tell us if this is of interest. So I really think that there is a change. Mike, correct me if I'm wrong. There has been something happening in Detroit as well, where there are companies and really important people engaging the disability community in some of this technology development. There are more and more sort of incubators that explicitly say, we would like to have. And I think that is wonderful, but it behooves all of us to be aware of this so we can direct our families to there.
Yeah, so direct example, I'm working with the accessibility team at GM right now, who are looking to engage the disability community more at the beginning of the design process when it comes to physical accessibility and also accessibility to the hiring process within GM. So you got accessibility going on from many angles right there. So that's just one example, but there are several.
And there are wonderful programs for this. I know that MSU has been really moving the needle a lot on terms of what sort of innovations can happen in the disability space. You often will find this at USEDS and LENS and things like that across the country. I think we're fortunate to be near Detroit, and there are actually several high-tech incubators all across Michigan where their industry comes together with entrepreneurs and with inventors, and they sit down and they have meetings and they discuss what things are beneficial. I remember being at a presentation and these people will come up almost like Shark Tank, and they'll present, and you have all these people questioning them. But it is mind-blowing to see that this is out there, and maybe some of these products don't make it big, but the fact that this partnership exists is important. So keep your eyes open, make sure that you're part of the conversation, make sure your clients and your families are part of this conversation. Or it's real easy to say, well, that doesn't apply to me. I'm not an innovator. but you are key to the families who will benefit from this innovation. So yeah, just be their advocates and say, and so today I'm already learning about all this stuff. Thank you, Mike, putting things in the chat, but I'll stop talking. I want more people to chime in. We've got about 8 minutes to talk about this question, so please. Anyone have negative perspectives of where technology for your client has not done as well, has actually created a new level of barrier access?
Well, so my discipline is education, and I do see that sometimes, because what happens is we assume the technology then is going to do the teaching, or that it's so user friendly that it's not an issue. So we have students who will be use technology for their accommodations or instruction, but they don't know how to use it. Or if they go home, their parents don't know how to use it, or the school's not allowing them to take it home, or the barrier of, for an example, we have a lot of students like with dyslexia who are ADHD who use apps to stay organized and use their calendar, etc., but they're not allowed to use their cell phones in school, or they can't access, Wi-Fi or the network. And so we haven't quite merged all of those components. And it's challenging as the teacher when they bring in new tech if you don't know how to use it. So the concept of that technical assistance that's part of the IEP is not utilized like it should be. So those become pretty significant challenges.
Amelia, you were going to say something.
Yeah, so I work with someone who uses voice dictation to like type emails and write blog posts and things like that, which has been super helpful for him. But with his intellectual disability, his reading comprehension and also his language composition is impacted. So he's using voice dictation, but it's not translating onto his email or in his blog the way that he wants it, and that's frustrating for him. So he doesn't have any kind of intuitive dictation device that's going to help structure his sentences. So that is something that could be beneficial. I believe that's available, but not on any of the free apps is going to say exactly what it thinks you said. So if you have any kind of speech pattern that's not typical, it doesn't capture what you're trying to say very well at all.
And that comes really back to the point of user-centered design. Did the people, when they were first creating these apps, did they take into account the different types of users and the spectrum of people who use it? Because that, again, I would say is a design flaw, right? If it is picking up only people with good diction and good sort of articulation, well, there are a lot of people who don't have that. And does that mean they have no right to access it? Or, as Amelia pointed out, they have to pay more to get an even fancier app, so that somebody with a disability has to pay for a pro app rather than the basic app just because they may have challenges in their speech patterns. But that's a great example. And the thing that I found amazing, and I know I put it in one of my presentations, is so we're looking for guidance on this, right? And we say, well, this costs a lot of money and there should be laws around this and there should be regulations around this and regulate big tech and tell them to do this. Well, the US government, 90% of their websites are, including websites of, ADA. It's not for every person. The font type is off. They put Flash, Adobe Flash, which messes up any sort of ability to do it. Again, so if the gatekeepers themselves are not minding, their business, why would anyone want to do it? And the laws have been created and then weakened because they go, yes, you must, unless it's too expensive or it's too cumbersome. Yes, you should, unless you're a small company and you say you don't have the experience. So now everyone's taking a loophole out, right? So where's the leadership, right? We're all small fry and we're great advocates. But if somebody is going to make a change, and this is again coming to, what can we do? And I know we're morphing into question 2, but I think, Amelia, you brought up that excellent point right there about sometimes what is presented as a resource actually becomes a barrier. Do other people have like examples where you had so much faith that technology was going to help your client or your patient, and it turned out to be more of a headache?
I know something that I've run into in the audiology world is the size of hearing aids now. There's so little, which is great, except if you have dexterity issues. And then they're very difficult to insert. So it's a trade-off for the aesthetics of the hearing aid versus being able to put it in and keep it in is kind of, it's something that we juggle with a lot of our patients.
One that I've encountered in my work history has been things with like Google Translator, with people speaking English as their second language. There's still like different dialects within different languages that just created another barrier because they weren't still able to convey or understand us completely. And it brought just a lot of frustration and felt isolation at that point too.
And, Catherine, you brought up an excellent point. I mean, we're all guilty of this as well. Our linguistic sort of equity is also challenged by the fact that not all of us have skill sets in multiple languages. And then we look to resources for that. Like we look for translation systems, we look for interpreters, but the content is missing. I mean, I can't tell you how frustrated I know Nicole and I feel when we see a family that speaks a language other than English in the medical arena. And yeah, we have an interpreter. But then when we sign the report and they get a handout copy, it's all in English. So we're expecting them to take these 5 pages home and follow the instructions, and there's no automation to convert it into their preferred language. So we're assuming whatever they heard with us over 30 minutes is then going to go home in their head, and then they're supposed to read this English document and figure out what we said. So it is frustrating that, we have technology to do all these things, but where's the user-centered design? Why is somebody not screaming, do you really not have something to convert whatever you type right there? So why is there no Google Translate, even though it's flawed, as you pointed out, in the medical record? So you can type, you may not know Chinfalam Burmese dialect, but if you type it and you select and it converts it, that is so user-centered, but we don't have that. I mean, so yeah, technology exists, but not in the right places sometimes, I think.
Yeah, more than just even the instructions, but like if they want to use like a My Chart type feature where you can instant message your doctor or easily request your prescriptions without calling in, waiting for them to hook you up with the translator, making your request, waiting for it to all get done, you could just click a button and say, I need a refill of my kid's med on for this one.
And going off of the interpreter aspect, during COVID, interpreters were transferred to phone interpreters. So like in the audiology field, we'll have a phone interpreter on speaker for someone who has a severe hearing loss. And it's very difficult to communicate because we can't turn that speaker up any louder than it already is. So you have this whole phone interpreter as a great idea to like make it so you don't have more people in the clinic, but then it becomes a barrier for people who aren't able to hear or need to lip read or anything like that.
Thank you, Kaylee. I appreciate that. And you guys are so perfect. The second question, it's time for that. So we just talked about a bunch of problems, right? Technology there, but doesn't work. So how can we be better advocates then? So what strategies can all of us think of in our daily lives, but also share with our mother that we can help this? I mean, we just heard many examples where things are not working as well as they should. So people throw out there what things maybe you have done that has helped, or maybe you tried but failed because maybe there's a way to make it succeed again. Just thoughts, any success stories, any stories that didn't go well, any frustrations, and we can think as a group, So what can we do? We're charged with being leaders. We're charged with being family advocates. We have expertise in all our individual disciplines. Why not us? Who else, if not us?
One thing that I've run into in working with kids with autism who may use a device to communicate is that sometimes, again, we think kind of like what Amy was saying earlier, like we give them this device and we teach them some things. And then again, this is going to like make it so they can communicate so well with everyone and all this. But then one thing I noticed was sometimes we would spend so much time on that while they were at our program, but then they'd go home and they wouldn't take the device out. And you'd notice based on like the battery level of the device every day. And it's like, well, okay, so we're teaching them this skill and there's this technology here, but then now it's not being utilized across like context, right? And that's a really big issue, especially if we're teaching them how to communicate using this device, then they need to have that device with them at all times so they can use it to communicate. So that's definitely an issue I ran into. And I think that's a situation where we can definitely provide some more like education to parents about that, right? And like explaining to them really the purpose of the device isn't just for them to learn how to use it at school. The purpose is they'll learn some things at school and then they're going to be able to practice at home too. And how important it is that if we're giving them this voice at school, that they'll also have that voice at home and in the community. So I think sometimes it's just a matter of spending that extra little bit of time talking through some of it and really providing that education to some other providers or family members about some of these things and how important they are.
Thank you, Allison. And we forget sometimes, as much as we're advocates and we want to help, it is not a one-way street. I have always believed that families also share the responsibility of doing what's best for their children, their adults, the clients. If you're going to be doing all the heavy lifting for them, you're not going to teach them to fish. You're always going to be, they're going to be dependent on you, and that does not teach autonomy. So I agree with you. Here's the device, I'm going to teach you. It's your responsibility to practice. You know, if you're having challenges, let me know, but I am not going to do it with you, right? I learned as a child, going for your piano lesson and then going home and not doing it till your next piano lesson matters not at all. If you're not putting in the effort to practice, you're not getting anywhere. And so, yes, the sharing of responsibility is key here. So you brought up, Allison, education, which is perfect. What other ways can you guys think about that you can be advocates other than educating clients? What else?
I just think simply if we find that a client is running into a problem, then we should contact the company maybe who has developed the app or developed the program to let them know so that they can then implement any changes that might occur. We've all found with Zoom that, you know, over the course of the year, there might be problems that we see, and we can contact Zoom directly to make that change. So I think just reach out to the developers of the program, the app, and ask them to make the change.
Agreed. And Madison put in the chat, and I'll summarize for both. You're absolutely right, Heather. Reaching out, every single piece of technology out there, they proudly proclaim on their website, contact us, customer support, professional things. If you reach out as a professional, it matters, and you can show that you're interested and reach out to, as Madison put it, understand some of this technology. I'll be honest, I don't know how some of this works. So I'd like to know. So I'd like to be directed to a technology for dummies quick webinar or a little product sample, something. So I can at least say, hey, I know a little bit about this, and say to the client, okay, and this is where you go. So yes, learn more about it yourself if you can. Like, I would love to get a pair of VR glasses tomorrow and just test it out, because I don't know anything about VR. I've heard it makes people sick if they move too quickly. Well, that's all myth. I don't know till I try it out. Nicole, I don't know if you know, but there's a terrific, for the last 5 years, a VR center right here in Kalamazoo that's underutilized. They have rooms where they set things up. You can come in and you can test it out. And so maybe we need to try that out. I didn't know it existed for years. But yes, testing out stuff, reaching out, understanding the tech, because, and then the other thing Madison pointed out, which is so key, looking at it from the eyes of the client, because you want to say, is this going to help Johnny? Is this going to help Mrs. Smith? Because if you believe it's not, you still run it by the client. But, you know, if you know, as you guys have pointed out, okay, this is not going to work for my client with the speech impediment, well, then you convey that to the company or you go look for another product. It's a very competitive marketplace. I bet you there's 5 more products just haven't been hyped as well that probably work as well, if not better. Other thoughts?
I think part of what we can do, I guess looking at it from an equitable lens, is like advocate for the cost of the technology, because it's like the haves and the have-nots. So if your family has resources, you have access to all these cool gadgets and different things like that. But if they don't, you're working with the bare minimum. And I guess modeling after the assistive technology, I hope we'll get to the point where it's similar to like medication. So you wouldn't tell someone, you know, because you have Medicaid, you can only get this type of insulin, but it's not the type of insulin you need. Like you don't get the medication you need, you get like the crappy kind. I don't know. Or just not the most effective kind. So because assistive technology is a lot of times key to someone being able to live independently, successfully, all those things, and hope that it would be available to everyone and not in a way that only people who have privileges get those resources.
Amelia, I agree with you completely. That is the key. And when you brought up medicine, it's true. Nicole and I and Crystal see this so often that, you know, because of vagaries of insurance and policies and stuff, sometimes you are right. People get something that maybe is not ideal, and we have to jump through hoops about prior authorization and appealing. And, you know, it gets old very quickly. You can advocate and you can advocate. But if you're hitting your head against a brick wall, we're all human beings. We tire of the game. We walk away from it because we go, this is not worth my while. And then the client suffers, right? There's only so many prior auth denials that you can run through. And then you accept that the reality of the society, as unfair as it is to give the crappy product to the person who can't afford it. But that should not be the first step. I agree with you. I mean, advocacy on the front end about, you know, equity and cost. And that's what I've loved about what's happening now, for example, in the internet space, right? So for years, people have railed about why does, you know, Spectrum and Xfinity and all get to corner the market in my neighborhood and I have to pay whatever it is? Well, there are always going to be disruptors and game changers. In rural areas, you know, basically Starlink is changing the landscape. People can get their high-speed internet at low cost rather than have to worry about some company laying down fiber to come to them. There's going to be disruptors. There's going to be disruptors in technology. Every time somebody has a smartwatch that's so much, there's going to be somebody who's going to undercut it. So we have to be mindful of the cost-effective things and not get hung up on the best product, because best, I would say, is only in retrospect when you've done enough studies or looked at the data, not because a company is hyping it. But yeah, cost effectiveness is so important. Other points of advocacy, other points that we should be thinking about as we push for equity and access of technology.
I think there's also systems level advocacy that can be really important. So thinking about, like, I know in like Rochester, downtown Rochester, they have the like accessible pedestrian signals where it like vocalizes whether you're able to walk or not, that kind of thing. I think those kinds of technologies, again, could be brought to other communities too, right? If we're making people aware of the fact that these things exist, and then we're, again, getting connected with the people who have the funding and all of that that can provide that. So thinking about like that could be for that kind of issue, maybe that's something that you bring to the city council or something similar to that, and attending those kinds of meetings and developing those relationships with people who have, again, the access to the funding to support it, or even just like the power to kind of implement those kind of changes can be really helpful. So thinking about advocacy, yeah, like both kind of like a local kind of level, maybe also state level, even a national level or international, I guess, depending on what the issue is. But I think really getting engaged with those different systems around you is important.
And I learned that today. So interestingly, we had a family who has been struggling to get their child to the ABA center because gas prices have gotten so high. They're on a very limited income, but they also have private insurance. They don't have Medicaid, so they can't rely on free transportation by Medicaid. Well, I was struggling. They were like, some days we have to skip it because we don't have enough money for gas to take her 35 miles each way because that's the closest center. Well, thanks to a fortuitous conversation this afternoon, we realized that there are grants that the families can get for transportation, and we are now having the social worker help them apply for that grant. Wouldn't have known that. It's not advertised, it's not common knowledge, which is a shame because families need to know this is there. It doesn't need a phone call on the part of the physician and the social worker to find out that there are grants for these things. But yeah, connecting with networks is so important. Advocating with systems is so important because they know things you don't know. And then you just, I love expanding the Rolodex. I'd be happy to hear other things you guys have done. Like, so Allison talked about, at different levels. What sort of out of the box things have you guys tried? Who have you guys maybe called to facilitate a client's needs? Like, how crazy did you get? Did anyone ever send an email to a CEO and rail about it? Did anyone write to their congressperson and say this law is unjust and it needs to be more equitable? I'd be curious.
Yeah, for the school that I was at, we apply for grants specific to different technologies periodically, but I know that our tech director would periodically, when we had Chromebooks, would periodically contact them because either the function wasn't working quite correctly or it wasn't doing what it was supposed to. And I did some work with Learning Ally to make sure that our kids had audiobooks, or at least access to audiobooks. But sometimes it's so dependent on model, because that was always our issue. Like, we could get it, but then once there's an upgrade, we can't use it anymore. So then there were times when we would communicate. We're like, okay, we had the old version, we can't afford the new version. And once in a while they would send, they go, okay, we'll just test this one out so we could maybe get one unit. But it was still an awareness of, it's cutting people off at the knee sometimes if you have your new version and you can't use the old one at all.
There are so many opportunities to advocate for law changes. Thanks to LEND, I'm becoming more and more familiar with it and my role on the Autism Council. Things can change. You just have to be willing to step up. You're willing to send an email. Very often there are forum emails. You just have to send it from your email to say that you support a bill or you oppose a bill that you believe is going to restrict access or make it more complicated. Many times you will have issues related to, so for example, coming to autism and access, there was a huge barrier around the number of times somebody needs an evaluation to prove they have autism every year, et cetera, et cetera. Well, I don't know if you guys know, but that is now gone. The latest version of the law that was signed in says you do not need annual ADOSs to continue to receive the autism benefit if you have Medicaid. And it takes advocacy, it takes time, but it wouldn't be passed if there weren't people standing up and saying, we support this, we agree with this. I mean, the same thing applies for, should people have that wonderful FCC benefit. So now families of low means can get so many dollars off their device, so much dollar off their internet. The program has fewer applications than they need. They want more people, and people are just not applying for free money. And it's absurd because when I tell people this, most of the clinicians go, I didn't know about that. And I go, It's your job to know about this because you can then tell your patient or your client this exists. So the FCC broadband benefit is fantastic. And people just have to apply, and that's it. And you will get so much off your internet bill, but also so much if you need to get a Chromebook or you need to get a tablet or whatever. And every dollar counts, particularly in these days of inflation and these days where, you know, people, families are still struggling. It doesn't matter. People feel COVID is slowly fading. I hated to hear what I did today from from Dr. Turner and others that we are the next 4 to 6 weeks, we're going to be exactly where Europe is now, which is not good shape. And I was like, okay, I just thought we're putting our masks away, and we're like, nope, all right. So 4 to 6 weeks, have fun, guys. But anyway, moving along from that downer. So I want to pivot. Before we talk about how telehealth can assist, I'd like to hear, because we're still talking about barriers and advocacy, right? What challenges have your families had in accessing telehealth? If people have wanted to connect to them for video visits, for therapy, or for assessments, or for their clinicians, what are you hearing or what are you seeing is a barrier? We'll come to question 3 exactly at 6:30 when we'll talk about how beneficial it's been and what have you seen. But let's talk about the ones who are not benefiting from it.
The ones that don't have internet connection or just that don't have that type of service in their home. And some families just don't know how to use, you know, like a Google Hangout or whatever platform, Zoom. And, you know, they refuse to learn sometimes, so.
Kind of going off what Angela said, I've heard some families say like about different providers, they see everybody as a different one. And so trying to keep track of, okay, this doctor uses this platform and this is how you use that one versus this one, because they're all similar, but they are different enough that if you have like 3+ providers, it's very easily confusable on how to do certain.
I've come across times, not so much related to the disability community, but children in the foster care system, because at least with the EMR that we use, that then gives the caregiver access to the telehealth visit, you have to be the legal caregiver of the child and not the foster caregiver of the child in order to access the chart. We found, like at U of M, we figured out like workarounds, but in this area, the foster caregiver doesn't have access to the patient portal, isn't necessarily able to see all of the notes immediately. We end up snail mailing the notes to the families after the visit gets, you know, fully signed by the attending and things like that. But that really sometimes delays in terms of the patient instructions that are included in the note or things like that. I found that for a lot of those families who are in the foster care system, they don't benefit as much from electronic medical records as other families do.
Yeah, and I agree, Crystal. The other big challenge is families who are not proficient in English. The translation systems are very challenging with telehealth because there are no good native embedded systems. So you end up with these terrible mix and matches where you've got a translate, like an interpreter on speakerphone trying to talk to the output speaker of the computer where you can hear the family, and there's this echo going around and you're trying to figure it out because it's a rare system which has enough interpreter services in-house where they can do it. Most of the time people are contracting outside with telephone systems, and they're not talking to the portals of telehealth. So the telehealth systems are uniquely designed to cut out people who have, you know, non-English speaking needs. And I found that very frustrating, and I haven't found good solutions around the country. I've talked to Denver, I've talked to Kansas, I've talked to U of M and all. The ones who are doing it well, they have resources to say, we've got an interpreter in-house, they sit in on the visit or they can be part of the network. But when you have somebody who's not part of your system, there's all these legal and procedural loopholes that they cannot come inside the electronic health record from outside. So if you have a Gmail address, no way we're giving them access type of nonsense. So now a family who doesn't speak English, what they're being told, well, we don't have telehealth for you, you're going to have to come in. Why? Why does this one get to do it from home and you have to drive in just because of the language you speak? So yes, I think it's inequitable telehealth when it comes to non-English speaking. And I agree with all of you that it's about technology access. It's about broadband availability. It's about comprehension of how to use it, foster, and many other things. What other sort of barriers have you guys seen when you've tried to do telehealth with families, if you have in your practices?
So I also do crisis support work. And when we offer or when we ask people, have they ever saw a therapist or utilize a therapist, the big issue that I hear all the time is, I don't want to talk to someone on the computer. I want to see someone in person. So there are people who could really benefit from the support who go without because they don't like that there's not even an option even now to see someone in person. And when I think about the people who I speak with who are maybe like in the UP who can benefit from telehealth because they can see people who aren't there because there's a very limited pool of mental health professionals there and they still won't give it a try just because they don't like the impersonal feeling of talking with a therapist or anyone over Zoom. It's kind of disheartening.
And you're absolutely right, Amelia. There's a lot of skepticism around this. The studies have interestingly shown that the younger the people, the more likely they are to adapt to this. So there's a generational change in that. The skepticism is tending to be older folks who have gotten pretty used to the way of in-person encounters with their professionals. The younger populations are doing a better job at adapting. But that does sort of cut out a whole bunch of people. And I think, coming to what you guys said earlier, education is key. I mean, demystification of video visits is important because the value that's added. The good news is for many therapies, cognitive behavior therapy, trauma therapy, etc., there is a evidence base out there that says that video encounters are helpful. And so we are doing the right thing by suggesting they do that. And then I take it upon myself to encourage people to give it a try at least once. Technology fails, no question about it. There have been times when it shuts down in the middle, it pixelates, people don't hear, they don't like it. But it happens, stuff happens. You could be driving to your doctor's office and have a flat tire. Well, okay, there you go. Stuff happened in life, so it's but people are accepting it more. I think the only worry is, and I don't know if you guys see the data, since March 2020, between March 2020 and June 2020, there was a 400%, so 4 times uptake in telehealth across the world. Boom, because nobody had a choice. And then as things started trickling, started falling. And it's back to almost baseline. And that's scary because what people have pinged it as, it's a pandemic thing. And it's not a pandemic thing. It's amazing for families who have to drive. I have a client who has to drive an hour and a half each way for a med check for ADHD. And the mom said, Dr. Soares, could you please give me a video visit like you did before? I said, absolutely. And she thanked me because she didn't have to drive, 3 hours round trip total for a 30-minute visit. And I'm happy about that because it's not a pandemic thing. It's really important. And the UP, it's important. It's important everywhere. It was important in Los Angeles when I was there because guess what? It's not that you're living in a rural area, but I swear to you, it took me longer to go from my home in Santa Monica to UCLA. 4.1 miles took me longer than it currently would take me to get from here to U of M. I kid you not. So 4.1 miles one day without an accident took me 75 minutes in Los Angeles traffic. They love telehealth there as well. So it's not a rural thing, just so you know.
Kind of going off that, sometimes like the impersonal nature of it can sometimes I've had what was supposed to be a video visit scheduled as just a phone call visit. And for certain visits, like especially my depression and anxiety follow-ups, it's really helpful to get that facial feedback on how the kid is doing, because those affective cues are super helpful in me determining how much improvement is going on, because sometimes the teens especially can be pretty vague, and when you ask like, well, how are things going? Are things better or worse? They're like, they're fine. It's fine. And so seeing how they're actually looking effectively is really key in knowing what's going on with them.
And Nicole,
But I'm
go
sorry.
ahead, Amy.
What Nicole said reminds me of, like, for some of our students or kids I would work with intervention, part of it was like a privacy issue. Like, they would give you very minimal answers because there were other people in the home. Whereas if they were coming in to see me, they were more likely to be able to see me one-on-one. And so, or they didn't want to have those conversations where, I mean, they can put earbuds in, but not always. It depends on whose device they're using. And so just the nature of them feeling like they had control over what was said and to whom and who heard it or who didn't hear it was not the same.
Amy, that's an incredible point. I agree with you. You know, the interesting thing though, also, I think some studies have shown that there's greater disclosure sometimes on sensitive topics through telehealth. So studies which have looked at drug usage have said that people are more likely to admit drug abuse when you're doing a telehealth encounter than in person, because there's something about having that screen that reduces the stigma of sort of disclosing and reading the clinician's cues of disappointment or disapproval. So it goes both ways. I agree with you completely that there's, you know, less disclosure sometimes, but there's also more disclosure. And either way, I think it's a family-centered choice, right? If you don't want to do it, that's fine. But understand that means you're going to have to come in. And if you're okay with that, who am I to tell you different? So, you know, I had a family in Kentucky who used to travel, I kid you not, 106 miles each way to see me for a quick check. And I was furious because I had telehealth going back then, way back then. We're talking about 2010. And so they, I said, finally, this is ridiculous. And they go, we love the shopping in Lexington. So this is our moment. Don't spoil it for us. I go, okay. I gave up because they would make a trip and they'd go to the malls and they watch movies and go back to their little town. So I don't want to spoil that, but the part of me which goes, you're spending so much time. They're like, nope, it's good. So yeah.
And I think Lisa made a great point in the chat about how much time it saves families in their busy schedules. And I was thinking, I don't know any numbers on it, but I bet it really helps with less canceled appointments and more follow-up visits with patients, just since they can do things from the comfort of their own home.
You know what I find, Emily, interesting on that is that it's actually a mixed bag. The data shows that what they believe, because it's so easy to schedule and follow through, if they miss it, it's not a big deal. It's not a burden. So you get that flip side. Some centers have shown that they have not had dramatic improvements in their show rates. It is reducing the burden on travel and time off. Because some parents are working from home, so it's gorgeous for them. They just go into the room and put the stuff on and it's ready to go. So it is helpful, but I don't think there's overwhelming support for improved show rates and less cancellations, because people are betting that it's no big deal to dial it up again, versus if they drove 90 miles, oh, by golly, they're not going to miss that.
That's an excellent point. This is Lisa. Yeah, I just wanted to just add, because, and you know, luckily I have been working from home since COVID began and still continue to do so, but just the amount of time that my daughter has had to miss from school, you know, because even though, you know, Mott is like an hour and a half away from, I live a little northeast of Lansing, you know, it's still, you can never get, you know, hard to get those very first morning ones, right? And you don't want to go right in the middle of traffic hour. So, you know, it has saved her from having to miss a lot of school days. I mean, obviously, it can't always be after school that we do a telehealth, and but when we can have those appointments, it's been really good for us. I've saved on my own sick time, in addition to being able to be home, and she's more independent. But I can understand what you're saying, though. Probably the same families, it's not as not, they don't think of it as such a big deal. Like you said, I had not thought about that aspect of it. That's interesting though.
There's so much benefit. There's also downside, because part of the problem is the clinicians, in my humble opinion, haven't had adequate training on telehealth to feel as comfortable with it over the years. They were thrust into this during COVID. They didn't learn the P's and Q's of doing it well and doing it to the comfort level. They're trying to translate their in-person skills to video skills without training on how to do it and how to measure fidelity. They're hearing everything on the, oh, sure, you could do that, before people have had enough time to actually teach you whether an IQ test is as good to do over video as it is to do in person. So this is that discomfort, not just on the clients, but it is also discomfort on the clinicians. And that is also limiting the rapid adoption, because clinicians are going, I just don't feel like this is good enough. And when they give that vibe, then the client goes, well, then I don't want to do it if you don't feel it's really good for my child, right? So there's that level into which clinicians have to improve their skill set in a way that they feel comfortable. They don't have to do every visit, but if they don't do even a few, and Nicole knows this because Nicole spent time with me and think, if residents don't do enough video visits, then the day they become faculty or practitioners, they're not going to do enough because they haven't cut their teeth on enough. And what happens if video visits becomes part of the norm? I'm not saying we deserve pandemics all the time, but I tell you that just like very few of us do our banking in person, pulling out change at a teller and trying to do things, we're using kiosks and we're doing drive-through and we're doing apps and we're doing automatic, and taking pictures of our checks. We're doing, our check-in on airlines on our phones. The day is going to come where the expectation of the clients is, you're going to offer me video, you're going to offer me portals, you're going to offer me stuff. If we're not ready for it as clinicians, we're doing them a disservice. So we talked about all the nonsense of telehealth. Let's talk about the great things. Tell me about what your clients have managed to get, and forget about the distance and time, because we know that that's a really good thing. But talk about quality. Talk about how you were able to deliver things to a family or reach them or connect them through video. That would have been challenging otherwise. What are your success stories?
I really like. Oh, was someone else talking? No. I really liked being able to see kids in their home environment, because a lot of the times, again, for something like an autism evaluation, we're bringing them in, it's a new place, we're new people, everything's very unfamiliar. And sometimes parents will say, oh, well, at home, it's a little different or something like that. So it's been nice to be able to see what they're like at home with their own toys, with their family, just kind of hanging out like maybe they normally would. Again, it's a little different maybe because there's a laptop in front of them or something, sure, but still trying to get a better idea of what their behavior looks like within an environment that's comfortable and natural is really, really helpful.
Agree completely with Crystal. We have enjoyed getting a sneak peek into homes and looking at behaviors. I used to collect a naturalistic video of kids in their homes when I was doing autism evals 10, 12 years ago, before we had, awesome video visits and stuff. And they would have to bring on a flash drive or burn on a CD. But now I can get to see it with a flick of a switch and I can say, Pan, let me see. So you're right. We see a new side of families, good and bad. I've seen this gentleman in his underwear chasing around his child, threatening to beat them with a stick. And I go, yeah, this is not working for me, sir. This is not working for me at all. You need to stop that now. I'm going to pick up the phone and call something on you. And he didn't think twice. And I'm thinking, if I wasn't on the video, how bad would this have been? So yeah, sometimes you see some bizarre stuff, but what else have you guys seen?
Well, Dr. Soares, just to kind of echo what you were saying about how sometimes you see the bad, sometimes that offers so much more insight into the dyadic in relationship between the parent and child. And I'm so sorry, there's waves being thrown all over the place. Having insight into the dyadic relationship between the mother and child and recognizing, and then also being able to understand the other stressors that the parent may be experiencing, which will influence like the recommendations that you provide, and will influence or like help you understand kind of the capacity of the parent in being able to carry out like a treatment plan. I think that that's been another really insightful thing when we do video intakes sometimes before we see children for testing.
Agreed. Amy, you were going to chime in a little earlier. Please do.
Well, I was going to say, one of the things that we found when we went to like remote learning, we had a student with severe like physical disabilities as far as his hands, and there wasn't really, some knowledge of why, but then it also became a situation of, if he was in person, he would rely on us more because everybody was in more of a hurry. Whereas when we were online, we just had to kind of go at his pace. So the benefit was that we could just schedule a time to meet with him one-on-one. And so then he didn't have to meet with the whole group. But we had this software, which sounds really like Big Brother vicious, but we, with teens, it was really good. As far as they were using their school device, we could see their screen. And so it ended up being such a really awesome like support for him, because I could log in and see what he was seeing and then direct him so that he knew if he was doing his tasks correctly or not. But then I also had him on camera so that I could talk to him as well. And we were really surprised at like just how helpful, that really was. And he started to feel more independent and be able to use his tech himself. I also have found, like, in a different way, like the telehealth, the education component. I belong to like a breast cancer support group, and we have people who live in the middle of like nowhere, and they can't, to drive in for 45 minutes and then be there for a half an hour, it's not really functional. But without that, we were able to share so much more education as far as what's current with treatments or medications or side effects and that kind of thing. So for that purpose too, it's been really, really powerful.
The other thing I found really amazing about telehealth is I'm able to incorporate more people with the same effort. There are families where one parent may be working and previously they didn't show up for visits. I've had people excuse themselves that their offices go into a private room and dial in, and now you've got different providers. Grandma could be part of it when appropriate. We've had the therapist be part of it, which would have been so much burden on so many people. And in a click of a switch, I've been able to get that. I found that absolutely amazing, because now you've got shared decision making with all the people who are important to this child and family, without having one person relay the information they got to 3 other people when grandma said when they went home, so what did the doctor say? They can all hear it at the same time.
I think one benefit that I didn't expect with the telehealth is that it has kind of pushed me to, well, it was initially the barrier of not being able to do a physical exam if it's like a very common acute visit. And it's helped me be able to force myself to learn to explain to parents like how I do some of the basic physical exam maneuvers, kind of empowering them. And I'm also explaining then what I'm asking them to look for. And a lot of them are then using that same information, like if it's like this kid maybe has a cough and trouble breathing, when they're calling back, like, okay, I'm noticing like he has retractions more than he did before. So it's giving them that education to use that I already have, but that they previously didn't, and kind of empowering them to have better insight into what's going on and advocate for their child's needs.
I think Allison put in about coordinated care. That's so true. In a flick of a switch, I can bring the social worker into encounter, say, hey, we've got a certain problem here. Can you help out? Otherwise, we'd have to page her, find out where she's at. I can see right there that she's got a green button. She's available. I tell the family. I found, as Nicole said, sharing of information. I can share my screen and go, look at this website. So somebody was asking me about toilet training in autism. and I'm old school, and I remember the Teach program at UNC and all their toilet training manuals and stuff. And I went ahead and shared that with the family. And then I said, you can also do this book. I try to train my daughter with Once Upon a Party. And so, you've got, and you can show them, and they're taking pictures on the screen so that they'll remember, and they're writing down the Amazon thing. And it would have been so hard to do in person, because then you've got all the other barriers. You go, wait, let me go to a computer, let me print this off, I got to find the printer. In real time, I'm sharing the growth chart and say, see how wonderfully your child is doing. Look at these little dots. And it's made shared decision making absolutely fantastic. Other things that have helped you guys through connecting through video, like what sort of great stories do you have? We've heard so far about family centeredness. We've heard about, time and distance savings. We've heard about, increasing everyone's skill set, democratization of information. You guys are being more mindful. The client is benefiting in some ways. What are the things?
Timeliness, I feel like doing video visits has, like, everybody's on time for their visits, and I'm on time for my visits, and I think it keeps the pace of the day going. And I think, the expectation that I'm going to meet you virtually in the virtual space at a certain time, I think it just has, I think it's increased satisfaction on both sides.
And what it's done for systems, and they're very reluctant to admit this, they're having less burden on their front office staff, who otherwise would have had to arrange, answer calls. Where do I park? Where do I come? Is it the first floor, second floor? Showing up in the wrong space, then having somebody to make them wait in an overcrowded waiting room and figure out if somebody's sick there or not sick there. And many individuals with disabilities, if they're not acutely ill, I'm concerned about them sharing the same space as people who may have illnesses that they could catch, or maybe in places where somebody is a little aggressive and somebody else is setting them off. It's reduced the burden. They don't have to do anything. I know they're showing up, everybody goes on the screen, and there's less to worry about. And I think that's a side benefit, because we know that employment is really hard now. I don't know about you guys, but we're struggling to retain nurses and front office people and, get qualified people. And well, this is one less thing to do. So tomorrow I have 4 patients at a trot, 3 of whom are video. So my nurse goes, thank goodness, I just have to room the 1 and I can do all the other patients who are coming in. It's a tremendous benefit for ancillary and supportive staff, at least in my opinion.
I know for myself, I feel a lot more likely to actually call my doctor about a problem I'm having if I can not have to come in to talk about it. If I can just be like, hey, is this a big problem, or am I just like having anxiety about it? I have done that multiple times throughout the pandemic. And it was enormously helpful. And I feel like I definitely wasn't sitting in an urgent care, clogging up a seat that somebody actually really needed.
I totally agree with you, Amelia. It makes it so much easier to work around my 8 to 5 resident schedule when I can step out for 15 minutes or 30 minutes to quick have my own doctor's visit without having to have the extra 15, 20-minute drive on either end to go physically there, get checked in, get checked out, and then come back to my rotation. I can stay right where I am, and it's a lot quicker.
How has audiology, speech therapy, OT and all done? Because, you get the sense that, if you have to talk to a person, that's great. But what if there are things you need cues, you need to figure out things that you previously used to do in person? How are you guys doing with telehealth?
I'm a speech therapist. I actually think telehealth is equal to in-person services. There are some clients who we do have to consider if it's a progressive, like primary progressive aphasia. We have to think about how they're able to access the technology as the deficit progresses. But overall, we've seen in our practice, we've seen similar outcomes, especially in speech sound disorders or language disorders. We're seeing the similar outcomes. So I think sometimes it's better and sometimes it's just equal to the service. We've also found that parents are more engaged, and so that's a nice way to have the carryover of the skill into the home environment, because before the parent might, sit in the waiting room, or they might sit in their car, or they might take a walk, so they're not actively engaged, where telehealth kind of requires them to be right next to the child to assist with any technology that may fail, or they might need to move through a screen. So I don't know, Callie, have you had telehealth experience?
Yeah, so I'm also in speech. I started in telehealth for my graduate career. So like we weren't in person. So I kind of did the opposite. I shifted from telehealth to in person. So I would agree it's been similar. But I think telehealth definitely required just a bit more planning on our behalf to make sure that we had our materials ready to go, or backup activities for our kids, because maybe engagement wasn't as likely in virtual settings. But other than that, I would say outcomes have been very similar, like Heather said.
Fantastic. Amelia did post that audiology is not using it as much. What other issues are there? I mean, so I get some aspects of audiology, but I mean, I've been curious. There have been some programs which do teleaudiology pretty successfully. I'm wondering if we're talking about specific examples in our region, because I'd hate to think that telehealth is cutting off a discipline per se because it's not conducive. So anyone else has audiology perspectives that maybe Michigan or programs here aren't leveraging it as much, or is it just a one-off?
So this is Janie. I would comment that one of the tricky things with audiology is the diagnostic part. I think the rehab part could be heavily influenced with technology, but we have not done a great job in our field in bringing diagnostic audiology into remote, although I would say it's coming. I mean, there are a lot of vendors who have created a lot of technology. The VA system is really promoting using telehealth to create diagnostic audiology. So I think in our state, it's a little slow, but I think it's coming.
Thank you for that, Janie. Yeah. I do think that some fields, and I think everybody on this call has great potential. If we were talking to a bunch of gastroenterologists or surgeons, they'd go, there's no way I'm doing that. I want to have the patient right in front of me. But a lot of us, because we're also sensitive to the fact that our families benefit from it in terms of the burden on them to access, it's just, as long as we're mindful that not everyone accesses it for all the reasons you described in the previous question, will be okay. And I think we need to keep that flag going, because I worry about the dip in telehealth utilization. I think that if we go back to the way it was prior, we're showing the promise and we're taking it away from families who really would like it, and they need to be heard. So even if 10% of your practice can be telehealth, just don't let it drop. Just don't let it drop. I'm trying really hard not to let it drop. So I'm actively saying to families, I think I could do. And you know what? They don't say no, but they're not initiating, except that one family. They're just like, fine, things are the way that I go, no, you don't have to come. So I think if you guys could do that, if you look at your client roster and you say, you know what, I think I can do this. So apart from what Janie's saying about, the diagnostic, if there's somebody who could benefit, you take the initiative. Don't you? But initiative not to force them, say to offer them, because they still have the right to refuse. And I always say, would you like to? And if somebody goes, I'm not sure, say, I'm comfortable. I think I could do it for you. And if I can't, well, I'll do as much as I can. And we could always do the other one, but we'll get 90% of it done. But I'm trying to take initiative because I'm not optimistic that families are going to insist that we do. And so this is where I think this would be a wonderful, again, advocacy and leadership role for you guys. take charge and say, I'd like to offer you telehealth for these reasons, and I'm comfortable doing it. Would you want to? That alone is a tremendous icebreaker than saying, well, let's see if they want it. Because I think that they trust you enough that they want to know if you want to do it. Because of the myths out there that it's poor quality, whatever. But troubleshooting is key. I'll tell you, there's nothing more important than ensuring that the encounter goes well. And that is really dependent on your systems, right? Do you have the support? Are you supposed to troubleshoot every broken connection? Are you supposed to figure out why you have no video? Are you supposed to figure out why the audio is bad? So, Crystal, please.
This is kind of piggybacking off of Madison's comment that she put in the chat about ensuring that there's adequate reimbursement for these. Is I'm wondering how much of the decrease in the use of telehealth is influenced by insurance paying for telehealth, and if, because my impression today I did an advocacy day actually with the AAP, and I was able to meet with some legislators and talk about like laws that influence funding and or legislation in general about the utilization of telehealth. And my impression is that it's going to be here to stay, and it's really more dependent on the providers offering that service, and that if it's something that Medicaid and Medicare offer, that other insurance companies will follow suit and ensure that there's going to be adequate reimbursement for these types of visits. So I just wanted to get your opinion or hear what your thoughts about that.
So I don't think that the dip back towards the usual is because of reimbursement. And the reason is the reimbursement, except for a few states which are dialing it back, the pandemic declaration by the federal government has not yet been stated as over. It is still an active pandemic. Until that time, DHHS and CMS rules around being liberal around telehealth offerings and telehealth reimbursement are in play. So it is currently not an issue, but I tell you that it will be an issue because the pandemic declaration only put off what was inevitable, which is we don't pay well. But guess what? Many states, and Michigan is thankfully one of them, has taken proactive steps about ensuring that home is an eligible site. So prior to March 16th, 2020, Michigan, I don't know if they knew it was coming, on March the 1st, 2020 says, the home of a patient is allowed to be a site where you can do video visits and get reimbursed. And then 15 days later, bam. So, but that is here to stay in Michigan. Many states are moving very quickly because the families are screaming at, you better not take this away. And the legislators know that they need to listen to families. So it is currently not an issue. It might be an issue. The places where it will be an issue is, number one, telephone is gone. Because there's too much fraud, abuse, and poor quality related to a phone-only encounter for all the reasons you guys can imagine, especially in our fields. So I don't know a single piece of legislation that says you could bill a regular visit for talking to somebody on the phone, because that was never there before. But the home is here to stay. Parity more than likely is where they say you should get paid by telehealth about the same as if you get in person. Not every state does it, but the majority of states are moving in that direction. I have the numbers somewhere, and I believe it was 42 states have some sort of parity law when it comes to telehealth. Now, I will not even begin to comment on mental health parity because that is absolutely horrendous. We won't get there, but that's mental health parity regardless of telehealth. People screw over mental health providers in person just as much as they do telehealth. But I don't believe, Crystal, it's there yet as a problem. I think it's to do with people got uber comfortable, like, oh, things are better now, I'm going back to things I used to know. So it is critical that trainees like yourselves learn from your professional societies or your mentors or evidence-based practice to be good at telehealth and to offer it consistently. It's not acceptable to say, I wasn't taught that in my training program. And yeah, no, because that's not fair. So for medicine, for example, the AAMC and more recently, the ACGME has insisted that telehealth be a core competency of training, not optional anymore. Programs have to put in telehealth competencies in their RRC documents. And now they're all going, oh, because we just did it. We didn't know what we were supposed to say. Well, start operationalizing and finding goals. because just turning on Zoom is not a thing to put in the RRC. You got to actually say we have protocols. So there are some good training programs out there, regardless of discipline. They're amazing, tele-speech, tele-audiology, tele-OT programs. Find them, go do your own personal training, and that will help. But that's the best way. Be very good at it, because it is inevitable. It's going to be part of your practice. So there's no excuse to saying, well, I had to do it during COVID and now I'm not doing it anymore. No, not optional. There's only 4 minutes left. So I want to leave you guys, and I want the faculty who have been so patient and so kind to attend this to chime in, talk about this session. As always, I've learned more from you guys than I could ever share, and I thank you guys. But please, Dr. Turner, Sharon, everyone, Janie, Lisa, please chime in. I'm thankful you guys are here.
Neil, I was going to comment when you said about, that we were poised in Michigan, that March, that to have it into the home. That came from some very strong advocacy from Children's Special Healthcare Services. And based on some experience, some grant-supported experience, we've been working on telehealth, promoting telehealth for children and youth with epilepsy for a number of years. But because of the rule that it had to be from one health care facility to another health care facility, it wasn't taking off. For somebody to have to go to their primary care doctor to connect with somebody else, it just wasn't taking off. And so with very strong advocacy, so there have been many months, if not a couple of years, of looking at policies and how do you do it and how do you make it so that it's not abused, that, and how do you sort that out? And fortunately, that is likely to stay. And also there are more resources, for training resources. Family Voices has some nice resources for teaching families kind of how to prepare for a visit, which is, it's nice to be able to draw on that, because my experience with telehealth is that very often, particularly early on, many of the visits did not go as well as they could because people just weren't prepared. They were talking to me from their bathroom or the bedroom or the probation office or in the car while they were driving. And, that's not a good time to have a good a good encounter, so or didn't have what they needed, and it was just a matter of not knowing what to expect. So there are, and the American Academy of Pediatrics is posting some things there. We helped our Michigan LEN participated with the Association of University Centers on Disability to create a curriculum about telehealth, and some of that is going on the American Academy of Pediatrics site to help on the kind of work that LEN trainees do, models of care for the assessment and diagnosis of autism using virtual means, as well as treatment and things like that. So not just the medical encounter or the interview, but other more nuanced applications that you've talked about today.
Emily, you had something to say, please.
Yes, sorry, I know it's about time to go, but I just have a quick question. So obviously with telehealth visits, you can get a lot of really good subjective information, but you're limited in the objective information that you can collect. So how can you kind of get patients to buy into this if they're skeptical that, they'll have to have an in-person visit no matter what?
I think there are I know that WPS and Pearson and all are trying really hard to make a lot of their tests, valid to do remotely, sometimes sharing of screens, sometimes having parents administer. Of course, it's not the same fidelity as if you were doing in person, but I would argue that there's more of a push to get objective data of video assessments. Autism is a great example where they're trying to validate a tool out of Vanderbilt, another one, the BOSA out of UCLA with Kathy Lord, and there's a real effort to address what you said, reduce skepticism by having objective data. I also feel that many of the instruments we use in person are totally doable remotely. Everything that Q Global does, whether it's a Vineland or a Basque and stuff, doesn't have to be done by paper when they come in. We've offloaded a lot of instruments virtually. There are some tools out there like Cognoa, etc., which will capture video and try and analyze it and provide you some sort of high versus low suspicion of ASD. So I think you're right. People are addressing that right now. I would just put it down to what is your comfort level? If you believe that the evidence base isn't there, then don't do it. But if it is there, don't shy away from it. We've seen studies which says the diagnostic accuracy of looking at families in their homes through video versus coming in person is pretty darn good, dependent on the clinician. You can't have newbie clinicians go out there and go, I think he has autism, if they've never done it in person first. So qualified clinicians are smart enough to look at what they're capturing on video and remember what they saw in person and elicit it. I've only questioned it one time actually on I'm not sure, I think she has it. And then she came in and she had it. But that's one in now 2 years where I go, I'm not sure. So I think it's okay. I think it's okay, but there is an effort to make it objective. All right. We are over time and I want to be respectful and I want to thank everybody for all their input, questions, and I'd love to get feedback when you guys get to give feedback. I'd love to learn what you felt, what you thought, but the participation has been superb. Thank you all.
Thank you, Neil. Another great session. And the feedback you can give is in your email inboxes right now. So please remember to fill out your evaluation. Appreciate it. And we will see you all on April 5th for the last Tuesday night session of the year, if you can believe that. Anything before that, please get in touch with us. Thank you all.
Thank you. Bye.
Have a great night.